Hello, everyone, and I'm so excited to be talking to you today. Welcome, Leslie Graham, who's going to be joining us for this conversation. And I have to say, as I was preparing this, and based on the work of Kitty Garrett, a phenomenal ICU educator, I felt a little homesick. I just looked at the pictures, listened to the discussion, or thought of the notes, and really felt a little homesick critical care. Leslie, your thoughts?
It really tugged at my heart as well. Hello, everyone. This is my very favorite topic around pharmacology and pharmacodynamics and just titrating those drugs, and how, as a critical care nurse, you have to have those excellent assessment skills and make these interventions very quickly. But also it was living with that tension of it not happening immediately. And as you see the blood pressure drifting down, you know that the antihypertensive or vasopressor is going to kick in. So yes, all very exciting for me, Sue.
And you know what, the one thing I think I so believe, and I talk, we teach a whole course in this in interprofessional practice, and it's so critical. And we always say, who else on the team could do this? I think this drug titration, not the ordering of titration, but the actual work in the patient room of drug titration with 8 pumps or whatever, there is no one else on the team who can do this. Do you think, I think it's nurses, right?
Yeah.
Who is involved in this, in the decision making that goes into how you're, and it's very finessed. And we'll show you some of the pictures when you walk into that room to be able to say, I get it, I see it, as opposed to, oh my God. So let's get to it. Let's get to it, Leslie. And this is a very informal lecture, right? We're going to try to really keep it close to clinical. And so we're going to use clinical tips, clinical rules, other kinds of things to really keep it close to clinical. And I hope make the learning stick. So the first one is that we often learn from copying each other. Don't you think that's true, Leslie? That we watch each other learn from a senior nurse?
Yes, exactly. And even the troubleshooting and problem solving, I would use as a senior nurse. I would say, well, what would Nancy do in this situation? So absolutely, that role modeling is important.
It is. It's critically important. But we also need to give a foundation that is principle based, because when we just uncritically adopt the practices of another nurse, we could run into trouble because they could be based on bad practices. So it's that idea that we need to be mentored by senior nurses, and at the same time we have to understand principle-based practice so that we can determine if somebody is showing me a way, a method, an approach that's valuable in clinical, or if somebody's showing me a way, a method, approach that might actually lead to patient safety issues, right? And so it's that idea that you are responsible for your own base knowledge, and then you learn more as you get into practice, right? The nuances. And that this is really critical. Knowledge, skill, and judgment are critical to that competence, both in IV administration, in particular today we're talking about titration, and also drug prep. When you're working in high acuity situations, you so often are preparing your own drugs, you're preparing your own drips, whereas when you're working on a unit, much less often are you having to do that, be part of that skill, except maybe antibiotics or something. But so you are, it is that to be efficient and effective at both drug prep and drug administration. Oh my God, Leslie, doesn't it make you smile?
And in fact, those are the old pumps that we used to use. Yes, absolutely, 100%. That tells you you're gonna have a busy shift.
Yes, doesn't it? And it's so important. You can look at that picture and say, OMG, or you can look at that picture and say, okay, I'm starting on the left, boom, 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 or whatever. And I tell you, this is the first picture that made me homesick. I wanted to get right in there. And that's typical, right? Typical in the ICU, less typical in critical care units like the ER, because ICU is finessed care. If you think of ER is save their life, stabilize them, ship them out. And Leslie's job in an ICU, taking from that stabilize and ship them out, is to work towards healing them, right? So to work towards much greater stabilization in a different way. So it's not one is better than the other. They're very different in focus. And when we talk about meds, very different focus. Leslie will have used, I think, in ICU, a greater range of meds than you typically see in the ER, because again, we're sort of that first point of entry, save their life, stabilize them, and then move to you. And it's you'll see much more finessed. Do you think that's a fair comment?
Yes, absolutely. And when we look at this, we often had an informal rule that if you had greater than 8 pumps or 8 infusions, that was an inverse relationship to their discharge from the ICU. So it really does demonstrate how ill these patients are and the finesse that the critical care nurse requires.
The one thing I'm going to note, and we can't keep talking about everything because we could be here all day, and I would be so delighted to do that. But for your own, I think, time management, the one thing I want to note is that through COVID, I've seen a move to have those pumps outside the room. Have you seen that, Leslie?
Yes. It originated when we were running out of supplies, initially when everybody was in isolation, and because the nurses couldn't keep changing their gowns and gloves because of the PPE. So to conserve PPE, they would actually put 3 or 4 IV connecting tubes together and put the pumps outside for titration. A good point, yes.
Yeah, which was a little bit shocking, right? It's a little bit shocking to see, and it was necessary in a measure of COVID is like a war zone in a way that you have to be creative in the moment. Okay.
Yes.
Example 1. Here's a great example. 36-year-old morbidly obese female patient, and she's admitted for an elective gastric bypass surgery. Post-operative, she vomited some blood. Do you think that would be normal? I mean, she had gastric surgery, right? Gastric bypass. So it's something to consider. It's always abnormal. Would it be expected or not? I'd have to know more about gastric bypass surgery to know that. So I don't necessarily have that answer, but I sure know how to look up that answer. They took her back to surgery. And again, it would be, is it a little bit or not? They took her back to surgery because it was anomalous in a way that tells me there's something wrong. She developed welcome to my life. Soon there'll be a child bothering me and my mom will wake up and be calling me. But anyways, I still love you and my focus is on you. She had a fever 102 post-op. Is that okay? No. So sometimes post-op you can have a slight fever like 37. I call 37.5 a fever. You don't because you're young and fresh and I'm old school. But 37.8, sometimes post-op, we would keep a very vigilant eye on that. 102 is American language. But so let's say she's 38.5. No, never normal. She has a dusky bowel. So what would that tell us? Dusky bowel is going to tell us about perfusion to her bowel, right? It's going to look at perfusion to her bowel. It would never be normal, never be a normal finding, and it would be concerning, right? Because we're going to be concerned that there's a lack of appropriate blood perfusion to her bowel. If we have a necrotic bowel, it's a life-threatening situation. That could be caused by the surgery and how they anastomosed veins. It could be caused, or arteries. It could be caused by clots. It could be caused by a lot of things. But there was no leak, right? So they found no leak. So interesting, important background. So day 2, she's got these drips. Dopamine. And if you don't know what these are, they may come up in this presentation. Some of them we'll talk about more than others, but look them up. So dopamine, a very common drug. If you're working in high acuity, you want to know that drug. She's got Versed. Now, Leslie, why she got Versed?
Because I believe she's intubated, is she not?
Yep.
So she's intubated, ventilated, and because she's on a neuromuscular blocking agent, the vecuronium is paralyzing her, she needs to be on analgesic and sedation. So midazolam or Versed is a sedative. It's similar. I'm thinking of an analoxic agent like Valium or diazepam. It's a benzodiazepine.
Yeah.
It's benzodiazepine, and so you need that with your morphine to continue to use paralyzing agents for this patient. And I just want to highlight that the other drug this patient is on is Bumex, which is an American drug. We would put them on Lasix. Right,
and I think Bumex is available in Canada, but we don't use it in Canada. We would put the patient on Lasix. There's no reason to have that specific. The patient is on morphine. The patient is on sodium bicarb. I'm just going to put that off to the side. I don't want you to pay attention too much to that because bicarb is, in this case, it would be warranted. In lots of cases, it's not. So just to be cautious about that, whenever I see bicarb, I always say, is this warranted, right? Because we ran into some trouble in the old days. We used to give a lot of bicarb that led to a lot of problems. So in this case, warranted. Insulin, she's on an insulin drip. She's on the Bumex. We said we would give Lasix probably. Vasopressin is another drug that you're going to want to know the name of. Leslie, any thoughts?
So vasopressin we're using it in this case as a vasoconstrictor, a potent vasoconstrictor to help shunt blood back to the vital organs.
She's getting packed red blood cells. So she's post-op, she vomited some blood. She may have had a large blood loss in surgery. It's really important to recognize that a gastric bypass, you think, oh, it's just like that stomach stapling. It is actually a very critical surgery. It is a complex surgery. You've got a patient who inherently is medically fragile because of that morbid obesity. So it's very complex. It should be done only by a real expert in that kind of surgery. So this patient requires packed red blood cells. As soon as I saw that, of course, I'd be looking at lab results, right, Leslie? I need to know where she's at and what that's all about. The vecuronium, and just, again, I cannot stress enough, Leslie, I know you and I are in such agreement. As soon as I see that vecuronium, I want to make sure, is the patient both paralyzed and sedated? You can never, never, never paralyze a patient without thinking, what is the sedation? Paralysis, they look calm and serene. The patient is not sleeping. The patient is paralyzed, and if you have not given sedation, the patient is screaming in their head because they are awake, right? So paralysis and sedation together, right? Paralysis and sedation together. And then the patient is on neosynephrine. Did you give neosynephrine drips?
On rare occasion, we would, because it focuses on more the alpha receptors, we would use a levofed drip.
Oh gosh.
And oftentimes the anesthetist would come in and just give a bolus of neo, just to maintain their blood pressure until you can get some fluid on board.
Right. And I would say again, ER, that's very unlikely to be a drug that you're going to give. That is a finesse drug that you would much more likely to be giving in an ICU situation. I think that's all I want to talk about there. And so yeah, I love this slide and I left it in because it is that like, oh my gosh, where do I begin, right? And that's just all in the day. And you might have this patient and another patient. I see patient loads maybe 1 to 1, 2 to 1. This is a complex patient. You hope that would be your only patient. You wouldn't guarantee it. And we're hearing in the midst of COVID that the patient loads are really quite extreme. But it's, is it like, oh my God, or is it, okay, start at the beginning. And I think the message here in this PowerPoint and this presentation is start at the beginning. Just start at the beginning and let's go through how to do that. First of all, for you, every single drug, you're going to go through this. What's the action of the drug? How does that drug work? And Leslie explained some of them, right? Is it, how does that action work in general, right? How does that, what is, and in the indication for your patient. So how does that drug work in general? And then why would your patient be getting it? So if we're talking about dopamine, Leslie, can you tell off your head how dopamine works and why we might be giving it to a patient who is hypotensive?
Dopamine is one of those great drugs, although we'll talk about side effects, but dopamine actually will target, they used to have 3 different ranges, and in a sense they still do. So there's a low dose of dopamine, so 0 to 3, 0 to 5 mics per kilo per minute, where it really just starts to increase that perfusion and open up those arteries. So I used to refer to that as the renal dose. We don't do that anymore because they don't really believe it worked on the renal arteries, but you would see that, I think it's just because it's increased perfusion. So there's that lower dose. And then there's the higher range, or the mid-range, which would be 5 to 10 micrograms per kilogram per minute, where it's targeting those alpha receptors. So to me, when I think of alpha receptors, I think of in the periphery, it's clamping down. It's causing that shunting back to those vital organs, the heart, the brain, and the lungs. And then there's those high range, which is 10 to 20 and then thereabouts, which is a beta range. Beta range is 5 to 10, where it's increasing contractility of the heart. It's just acting on the heart, those beta receptors in the heart, to increase the oomph, so getting that perfusion going. And then the 10 to 20 is the alpha range, where it is massive vasoconstriction. It's clamping down on the periphery, i.e., to me in my mind, and when I see the patient with those mottled looking legs, it's clamping down in the periphery to shunt that blood back to the vital organs. So there's a lower dose range, 0 to 3, 0 to 5, 5 to 10 or 5 to 12 is your mid-range, which is your beta range, which is increasing contractility on the heart. And then you've got your high dose, which is alpha range, causing that massive vasoconstriction.
Right. And the point you made, thank you, Leslie, that typically we've moved away from that low dose range, using that low dose range. But you know, I think often one of the expressions we use, and I apologize, that's Katie girl. One of the expressions that we use is what's old is new again in medicine. And so you go well away from a medication and come back to it. And I think of Levophed, you mentioned that on the previous slide. Levophed used to be sort of a drug towards the end of your choices. And there used to be a kind of a coarse expression that is Levophed leaves them dead, because it was a drug that went, by the time a patient was on a Levophed drip, you were getting to the end of your options. And then Levophed had a resurgence to be used earlier in treatment and to be more effective, right? So I think what's old, you know, we move through these cycles. Don't you find that, Leslie?
Yes, dopamine's a very old drug that has been included in the ACLS guidelines year after year after year. And I just want to just highlight that with these drugs as well, that there is downside. So I just want to make sure that everybody's aware that there are some complications. So for dopamine, the higher the range, the more arrhythmogenic. So I have to find that balance of the side effects and the drug itself. The other thing is with dopamine is that I've actually oftentimes infused dopamine at 1 mic per kilo. Ooh, that's like just nothing. And yet that patient required it to maintain their cardiac output. Just that little bit, that little sniff.
And I think a good point there is, and don't feel overwhelmed with this, we're going to keep going through the slides, but a good point there is that there are recommendations, right? There are recommendations and the expectations. And dopamine, typically now we're going to see the 5 to 10, the 10 to 20, those two different ranges, whether you're looking at the beta receptors or the alpha receptors, whether we're looking for increasing that contractility or whether we're looking to clamp down in when we're getting to dopamine at a higher range. But the side effects are really important in recognizing that as we go up to those higher ranges, I'm going to see more of that side effect. So that adverse effect that we see on the bottom slide. Recognize that some medications that on those drips are going to be titrated. That means we're adjusting them, typically adjusting them to response. And I think that's a really important, just to have that phrase in your head. You're adjusting to response. Sometimes we get a scale, like a sliding scale, for example, in an insulin drip. We may get a scale in terms of blood pressure or something like that. It might be more, it might be specified for you. Or it may be that you have a range that you're aware of and you're going to titrate to response. We're looking for what is the outcome? What are we expecting here? Is it that we're hoping to maintain someone's blood pressure? Is it that we're hoping to help maintain both paralysis or sedation? We'll talk about that, how we would assess for that. So what are we hoping that medication will do so we can assess the outcome, right? That's going to tell us if the dose is correct. We're going to look at what are my interventions in relation to that. So for example, if I'm running a heparin drip, if I'm running an insulin drip, those are very common. You'll see them not only in high acuity, but you'll see them on all kinds of units. What are the interventions associated with that? No one needs to tell me that I need to be checking PTT if I've got a heparin drip. If I don't have an order for that, then I need to get an order for that. So that's a nursing intervention that I would expect. To get that order if I don't have one, or to follow through on that order and to be checking the result. That is my responsibility, to be checking that result. Additionally, if I've got, let's say, and we'll use a simple drip, a heparin drip, I'm watching for bleeding. I'm watching for early signs of bleeding to make sure that I'm not having any of those adverse effects. On an insulin drip, I'm not just waiting for the blood sugar to come back from the lab or doing my glucometer readings every 4 hours. If I'm watching for early signs of hypoglycemia, right? I'm watching to see if I need to intervene earlier to assess further and to make changes according to that. Here we go again. This patient example, neosynephrine at 10 mils per hour. So here we have mils per hour. Versed is running at 5 milligrams per hour. And the insulin drip is at 0.5 units per hour. So important that you recognize how the dosing is ordered, right? So how we are running those drips based on, so typically to this point in your program, you would have been talking mostly about mils per hour, right? So when we're running antibiotic, when we're running other infusions, it's mils per hour. You may have seen units per hour with an insulin drip. That's somewhat common. But otherwise, it's really important that we're looking at milligrams per hour, micrograms per kilogram per hour. Other thing, we need to know the units that we are working in.
Sue, just a quick, to know the drug that we're actually infusing, because we're looking at the range, the minimum, the maximum. So we're looking at that. But also, if I could just remind everyone that we also need to know the total amount of fluid that we're infusing these medications in. So as you've got 8 infusions being administered, you might be running hundreds of cc's an hour. And so you need to maybe get an order to concentrate those drugs even more. So if you're running an infusion of dopamine at 400 and 250, you might need to concentrate that to 800 and 250 so that I'm running half the dose. So I'm running it at 5 mils an hour. I'm really restricting my fluids. So I just wanted to point that out.
Thank you, Leslie. I think so important. And I think the point I was trying to make, and I lost track last time, is although we have an expected range, there are times with consultation that the physician may order beyond that range, or you may even titrate beyond that range. The person that I think is so important not to forget from the interprofessional pharmacist. The pharmacist is your absolute ally in ensuring that we are giving the right dose for the right effect. And the pharmacist can be intimately involved in this process. So if I'm not sure, and the physician would say, oh, run that dopamine at this low dose. Leslie, I think, what did you say? It was 1 mic?
Well, dopamine would be a typical low dose dopamine would be 0 to 3 to 0 to 5. So yeah. So
but I'm not used to having it such a low rate, because now we mostly start at 5. But I might ask somebody, can you help me to understand this? And the person to ask may be the physician. The physician may be willing to describe it. The physician may be doing a lot of things in that moment, right? They may be looking after a whole bunch of critical patients. They may be working on night shift and they're just absolutely exhausted. But the pharmacist is a great person to pick up the phone and say, I've got this order, I'm just not understanding it. Could you help me to understand it? And they are an incredible resource. So don't hesitate, an incredible learning resource. Wouldn't you say, Les?
Yes. Oh my gosh. And they have a pharmacist sitting right in the unit.
Yeah.
For that very reason.
Yes. Okay. And then this critical point. So you walk in the room. Remember, we've seen these pictures, a million different IVs. I see something in a pressure bag here. I said, you've got a whole bunch of stuff going on. It's simple. Just break it down. I'm looking at one drip at a time, one line at a time. So it's very orderly and organized, and not to take in that big view and become overwhelmed. So when we looked at that picture, we saw Versed, we saw morphine, we saw norpurone, we saw that Zosyn, which is an antibiotic that we would use. Leslie says we use it here. I have not used it in the ER. We saw a dopamine drip, we saw Levophed, and we saw 1,000 cc normal saline bag. And all of them are mixed differently. So there are standards for how you mix it. And for example, the dopamine 400 in 250 cc's standard. But you remember Leslie said, if your patient is getting a lot of fluid and is not tolerating that fluid, or you're concerned about cardiac status, or the patient is developing edema, you may determine that it might be appropriate to mix it in a more concentrated fashion. So you're not going to just independently make that determination. We would follow these standards, but then we might, the team may decide that you're going to mix that double strength, for example, or something like that, to watch that fluid. Did you want to jump in? I didn't know.
No.
Okay. So important, but I would say important to recognize the standard dosing. When you're mixing up these infusions, it's sort of like a standard language. Everybody is going to be expecting that standard concentration. And if you're mixing it yourself, you need to make sure it's that standard concentration unless otherwise indicated. And you communicate that very efficiently in reports so that it's highlighted. Okay, and here we go. Right drug, right patient. Simple. We do that with every single patient, right? The simplest IV infusion, we're going to be doing that. Even giving a PO med, we're going to be doing that. We need to know both our generic and trade names. The generic names are often so awkward. I really think they need a better system for developing those generic names. I know it's often related to both trade and also the how those molecules work together, but they're often very awkward. But the generic name is important because that tells us more about class as well, class of drug, and also the trade name that we commonly use, right? Look at all your pumps. Now, one of the things you'll see in this picture is, do you see above each pump, there is a label. So you know without looking, oh, do I see that midazolam down there in the middle one on the pump? They've also labeled above it. Now I'm going to confirm that. I'm going to look in both places. It says Versed above the pump, and it says midazolam in small writing below the pump, in the pump. I'm going to confirm that those are the same, because that's part of my checks, right? I'm going to check, and you start right up at the bag and you're going to go through. But here we have our different settings. And it's important that we recognize that we need to be efficient in using our pumps and confident. So it takes a while sometimes to be very confident with a new pump. Don't you think, Leslie, when you get a new pump in, it can feel like it feel like quite a change, because you can use a pump quickly and without even thinking, and that changeover can slow you down a lot as you're remembering the new way to do things. But they follow the same standard principles.
So Sue, just to jump in here for why we have this good visual, I just wanted to point out that it is a patient safety initiative that we actually label the pump, as you can see above the pump. And a lot of times if I can just bring your attention to the actual pump has got it set. So if you look on the insulin, you'll see in very faded letters right under pumping insulin. So it needs to highlight what the drug is. The pump needs to highlight that, because there are guardrails in the computer software in the pump, so that it's going to highlight to me when I'm outside the parameters, because you're in a hurry and increasing your dopamine. Maybe I've increased it to 200 micrograms per minute by mistake. It's not going to let me do that. So that you need to have it set in the pump. You need to have a visual above so that you can see right from the end of the bed how much you're infusing. And also when you're doing your assessment, that you want to, what do they call it, spaghetti? You want to just make sure that you identify that tubing right at the patient site, so that you can ensure that it is infusing. I have to tell you that we have had the odd tubing that I thought we could see it at the bedside, but it actually was going onto the floor.
Yeah, I've seen that too. And it's kind of a shock when you walk over to a puddle, right? The other thing I just want to draw your attention to, and I know you know how to use a pump well, but at the bottom, in the middle one and to the right, the insulin and the Versed, that's where it's showing you your units really effectively. So you see your rate, both of them, or the middle one, the Versed says 5 mils per hour. The insulin says 0.5 mils per hour. Knowing your rate is fine, but knowing what that translates to in the amount of drug is really critical as well. And it's going to show you that 5 milligrams per hour for the Versed. And for the insulin, because you've put the name of the drug in there, it gives you your units well. So it's going to be 0.5 units per hour. So sometimes we're looking at mils per hour in, I don't know, just plain fluid or something. But we really want to know the units that we're using. Is it micrograms per kilogram? Is it milligrams per hour? So it's really important that we have those correct units, because that can be lethal if we're not careful about that. And so your pump is going to show those, and you're going to look at that very carefully. Leslie was talking about this. Oh my God, Leslie, this picture is just, you think it's ridiculous, but it's not ridiculous, right? But start. So again, remember, we're starting just at the beginning. We've looked at our pump. We're starting now at the bag. We're going right up. So we want to trace that line all the way down to the patient. And this one here is actually connected to, is that a blood pressure cuff it's connected to?
Yes, yes. But I think the point of illustration and the horror of that, to make it really imprint, is that we need to have this piggyback, this site, this port labeled. So this could be your bolus site, it could be your insulin or your dopamine.
Yeah. And I think the next slide is this, the clinical tip 2. Tubing misconceptions can be deadly. And so and this is an interesting, oral syringes, process problem. So you're going to use the right equipment to be working with IV pumps. When you have a multi-channel pump, it's really important that you don't mix them up. Take your time, make sure everything is labeled appropriately. You know, at nighttime, we want to let patients sleep. We have the lights dimmed. You're going to turn on the lights. It's very appropriate in many situations to let patients sleep. Sleep is a healing time. It's the time when your brain actually heals. But it's not helpful if we're killing our patients by having the wrong, let's say the right drug at the wrong rate. So we're actually going to have those lights on. Hopefully our patient is sedated enough that they are, not noticing anything with that. And we're going to follow through on this process, and not just once a shift. I'm checking my IVs. I'm not going to necessarily look for different disconnections, but I'm always checking those infusions. If it becomes disconnected, this is a really critical point. Don't let somebody else in the room reconnect it. Let's say in the middle of a code, something becomes disconnected, and you say to the, I don't know who you would say it to, the person who's going to take blood gases to
the RT.
The RT, yeah, can you reconnect that? No, right? There are actual stories where things like an enteral feed has been connected to an IV, or they've got IVs and trach cuffs connected in crazy ways. There should be a patient safety initiative where these things do not connect to each other. The problem is that you need to use the same syringes in various equipment, and so the ports need to be able to fit. But it seems inconceivable, but these things have been connected. Okay, now we're looking at our lines. Are the lines labeled? So we've got our bag labeled, I've got my pump labeled, and I've got my line labeled. I can't stress strongly enough that everything needs to be labeled, and that's why we take one. I don't look at my pump and look at all three settings. I take one line at a time and follow it from the beginning right to the end. And that's where you see a nice example here in a triple lumen central line. And this is an interesting question. Do you need to reorder the drip? Do you have enough in your bag to make sure that it's ready to go? There's enough for the next shift. And also, is the sequence that it's set up in making sense? Clinical tip 3. Always make sure, oh my gosh, that there is a bag of vasoactive drug. So we're talking about a premix of, what's a good premix, Les?
So dopamine comes premix 400 and 250 or 800 and 250. Pretty much just dopamine becomes premix.
So you want to make sure that any drugs that are available in a premix, that they're ready for the next shift. If you're getting ready for the next shift and your bag is almost empty and you need, let's say you've got an hour left of your drug, I would actually mix a new bag and hang it, because the nursing assessment in the morning in a high acuity area is going to take much longer than you would anticipate. So what we don't want to do is have a patient's pumping that they're out of their medication while I have yet to finish even assessing what's going on. So really critical. So then I would discontinue, or I would take down the bag that has a little bit left. On my own shift, I would run it for another hour. But if I'm getting to change of shift, I would switch it over and reset the pump. If it's going to run out near change of shift, there's no point in pre-mixing a bag for someone else. I wouldn't hang a bag that somebody else has pre-mixed. The nurse needs to mix her own bag, his or her own bag, if you're going to hang it. Any thoughts from you in your practice, Leslie?
Well, in the ICU, sometimes when we're running so many drips, and don't forget, this patient, if they're using 8 drips, they've got a hemodialysis perhaps, or an intra-aortic balloon pump. So I've got a lot of stuff to keep an eye on. So that's one thing I could delegate, because when you mix up the bag, you're mixing up and you're signing it. So I wouldn't hang it if it didn't have someone's signature that I could identify, but I would have some of my colleagues mix up some bags so that I was ready.
And so a really good point here. Do you see the difference in practice? Again, we both are high acuity nurses, but we work in different ways. And the circumstances in which we're using these medications is so very different. Okay, here we go. Steps to infusion. So we're going to interpret or verify the order. What is the order saying? Does it make sense? Checking for allergies. The patient's not talking. I'm looking for a band. I'm also checking in the chart, Make sure that record has gone to the pharmacy. Typically, that's an electronic process now, but we want to make sure that pharmacy is ready for us. And check to see if that's a medication that has to be mixed by pharmacy, that it's available for me. Or a lot of, in high acuity, you're mixing a lot of your own medications, your own infusions. Ensure that IV is patent and that I have enough IVs, right? That I'm not using every line for a drip. I always want one site that is left available for me, right? One site that does not have something infusing all the time. Ensure that the drug is compatible with the solution that it's going to run in. Ensure it's compatible with other meds. Do you remember that picture we showed a few minutes ago that you have, where you have lots of triple lumen? You have 3 drugs going at the same time. We need to make sure that they're compatible, because they mix in that small tubing there that goes through the port.
Sue, I just want to also highlight that you may not, our triple lumen may be already used up, and you're actually using a manifold that will have like 4 little areas that you can plug in the tubing, or we have had to actually add 3 or 4 stopcocks so that you make your own port. So all of these drugs are mixing in that tubing, and it's really critical, especially when you talk about the bicarb that you did earlier. Bicarb is so not compatible, and I've actually blown apart a triple lumen because there was some residual bicarb in it that I flushed it, and there was still residual. So I just want to point that out. And getting back to the bolus, having a bolus line, it is so critically important. That's the first thing I do when I come on in the morning. Where's my bolus line? Because I can do anything else at a leisurely pace, but I need to know what that bolus line is, because that is that person's lifeline. I want to make sure that I have a line that I can give a drug, that I can give 10 mils of something or 500 cc's of fluid or something through without compromising their blood pressure. So if I'm putting it through this line with all these 8 infusions, I'm going to bolus them with dopamine, and that will be a problem. So I need to have a line that is separate from all of those. So that's why I would put stopcocks together, put that onto one of my triple lumens, and leave one of my triple lumens for my bolus.
And so I'm gonna repeat this because it's a really important concept. So I used to always think of it as a clean line. Do I have a clean line? And so that means if I were to start something really fast, or if I were to start something that would have not necessarily be compatible, let's say I need bicarb, rare, but whatever, that I have a clean line, and that I'm not, if I started quickly, that I'm not going to be giving a bolus of the other medications that are already infusing. So for example, if I said, oh my gosh, turn off this drug, this drug I could turn off and give it a bolus, right? So I don't have any extra lines, but I could stop, I don't know, an antibiotic, give this. Keeping in mind, as soon as you connect, you've got drugs still in the line below the connector. And sometimes a tiny volume can be catastrophic, right? So you really need to be careful about that. A common place we'll talk about that is in anaphylactic shock, that when you're disconnecting the line, I don't start running an infusion of normal saline to bring up someone's blood pressure when they're having an anaphylactic reaction, because I don't just put it on the line I have, because I've got drug all through that line, right? So I disconnect all the way down to the port, right down to the angiocath. The same thing in recognizing where is my clean line. Do I have it as a lock? Do I have it as as Leslie's talking about, one of my central line ports? Where is that clean line that I am ready to use it? That is a life-saving practice. And it's so very important. When someone is crashing, you do not have time to start a new IV. And so you need to be able to respond quickly. So again, looking at drug compatibility and interactions of multiple drugs. Remember, we've talked about 8 different drugs. How are those drugs interacting? Some drugs have no effect on each other. Some drugs potentiate each other, and some drugs have an effect that they become less effective in combination with other medications. So you need to know all of that. Vital signs are so incredible. We're watching these moment by moment. That continuous monitoring means continuous monitoring. I have a sense in my head of where this patient is running all the time. It's sort of like, and I'll give a comparison, I don't know if it's helpful. You know, when you first learned to drive and you had to like look at everything you're driving, like, and you looked at the road right in front of your car, and you had to look where the white dotted line was, where's the yellow line, look at the speedometer all the time. You had to be like, and it took a lot of energy. I remember, gosh, getting out of the car being so tired because it just took a lot of energy to drive. Now, when I drive, my car is part of me. Right. So it's not, you feel the space of your car all around you. And I think that, so I don't have to watch, it's not that I'm not watching, but it becomes a process that doesn't require as much conscious thought. The same thing with your patient. You need to feel that patient all around. So like that idea of wrap your consciousness with that patient, so you know who they are and where they stand and what we're watching for. Right? So it's not little bits of information, it becomes the story, the moment by moment story of your patient. I'm not sure if that's helpful, but for me, that is a really good comparison. So we want our vital signs. ECGs, we're doing ECGs all the time, right? We're doing ECG. We're looking at a monitor, and we'll be doing lead 2 is running typically all the time. Sometimes we turn to other leads depending on a whole bunch of things, but typically we're going to be watching lead 2. And we're also going to look at the hemodynamic parameters. We'll talk a little bit more about hemodynamic monitoring, but we're going to have a good sense of where our patient is and a good sense of what does that mean. And one of the things that I work with is this idea in my own practice. It's so inconsequential, I'm sure, to everybody else, but I'll share it. It's the fine pile. When I am looking at information and all those pieces of information are coming at me, can I say fine, 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 fine? That's all going in the fine pile. Oh, not fine. And now I'm focusing in and pulling it together. When I say fine, 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 that doesn't mean that I'm disregarding it. I'm paying attention to it, but it doesn't have to be at the front of my mind. Blood pressure, fine. Heart rate, fine. O2 sat, not fine. So it becomes not fine. That means those other things I've said go in the fine pile. I'm bringing them back out to look at them. Remember, we talked about vital signs in combination, right? We're looking at patterns. But that fine pile for me enables me not to have to use so much conscious energy remembering all those separate things. So sometimes when you say vital signs are within normal limits, so certainly we wouldn't do that when we're doing transfer of responsibility, transfer of accountability. We are more specific. But that idea that in my own mind, I would be saying, I know what the parameters were for the ideal blood pressure for this patient. I see that we're in that range. We're good, fine. So I don't have to remember exactly what that blood pressure is. I know I'm good. If I was at the very low end or the very high end of something, I would pay attention to it. It wouldn't go in the fine pile. Does that make sense? Does that make sense to you, Leslie, as a practitioner? The idea that I don't have to remember every single piece of information at the front of my brain. I need to be able to recall it, but I also need to be able to take some data and say that data is okay. I'm going to focus on some other data at the moment. Okay, let's see. My patient is paralyzed and sedated. Do I need to talk to that patient? Do I need to tell the patient we're going to start a new drip? Your blood pressure is a little bit low and we're going to be starting a medication that's going to help that. It seems that you may have an infection and we're going to be starting an antibiotic. Absolutely, all the time. So just because a patient, and this is so critical in high acuity, a patient is sedated and paralyzed, does not mean they don't know everything that's going on. Please, please, please do not assume that that patient is lying there and is an object of your care as opposed to a human being receiving nursing care who requires the same consideration as a patient who is sitting up in bed talking to you. And make sure, again, infusion pumps, everything runs by an infusion pump now. Everything, Leslie. I know you made that point the other day when I said, I don't think our students have seen Buretrals, and you said, oh, because they don't use them. So I think, or micro drip tubing, I think everything's running by an infusion pump. What we know, an interesting study that tells us that you think you're running out of pumps, there are pumps squirreled away everywhere in the hospital, in like change rooms, in clean utility rooms, they're squirreled away on every unit. And we should have a code, like a stat pump needed somewhere code, because what we know is that a large percentage of pumps, when we can't find a pump and we're spending a lot of time trying to find one on a unit, they're actually squirreled away, they're hidden away because units don't want to give up their last pump, right? Okay, clinical tip 4, know how you prepare something. Precisely, know how you prepare it. Double check all those calculations and double check them with another RN, right? So you've got somebody who's helping you with those calculations. Make sure that there are any cautions that you should be aware of. So you're starting a nitro drip and the patient's already on something like beta blocker, ACE inhibitor. Both of those things may affect their blood pressure in combination. So am I being cautious about that use, watching, anticipating what happened next? Or let's say I'm starting a heparin drip. Heparin drip, I'm gonna look at the PTT to see where the patient is at, and I'm going to anticoagulate them. But the patient may have come from a unit and been on Lovenox already. So what is the interaction? What am I looking for in that situation? And even another simple one, if I'm starting a nitro drip IV, and the patient's on nitro paste, I need to make sure I'm taking off that nitro paste so that we're not going to have that double interaction. Central line.
I just want to jump in here that when you are doing your double check of medications, could you please make that an independent double check? Make sure you go away and do the calculations that your colleague has asked you to double check. And likewise, you make sure that you're doing them independently. And so one of my early errors in the ICU is I didn't do that. I actually convinced my nurse educator of my error, and I was running dopamine, and I did my calculations, right? Oh yeah. So I thought I better go over and turn up my dopamine, which is incorrect. You always titrate it. So I just whipped it right up there and put the patient in the defib. So always make sure, fortunately I could defibrillate and we were successful, but always make sure that you do an independent double check.
Perfect, Leslie. Thank you.
Thank you.
And really critical, we need central lines. In this case, we're seeing a jugular line on a patient. It is less a favorite of mine than, depending on time. It depends on, a lot of things depend on time. How long is that patient going to be with you? Was that patient in the OR or other things? Whether you're going to get a subclavian line or a jugular vein. Leslie, I think you told me that they're not doing subclavian lines as much as they used to.
IJs are much easier for the physicians,
Yes.
the ICU intensivists to actually insert. Subclavians take a lot of skill. They're great from nursing management, but they take a lot of skill to insert, and you're afraid of a pneumo.
Right. Big risk with a subclavian line is a pneumothorax. Leslie used the expression IJ, internal jugular line. You'll also see patients coming into the ER and please don't coming in. Okay, hold on just 1 second, guys.
So you need to have that central line to infuse all of your medications. And if I could just draw your attention to that IV, that you have the 3 ports, but also with this central line, you've got a cordis or a 4th port added to that as well. You could also, using your central line, you can measure the pressures in the right atrium. And we'll talk about that in weeks coming, how you can do a simple, you can get some really good information from that central line with that particular type of system. So a central line is essential for all medications when you're infusing them. Now you may have to start a peripheral line. When you're in the emerge department, you may only have a peripheral line, so you have to switch it over to a central line. And again, takes careful titration to stop the peripheral line and get the central line because it's hitting so much more quickly. Sue, is there anything I missed?
No, just the one thing. So again, here I'm going to talk a little bit about difference in practice between the ER and the ICU. And you said sometimes you may have to start something in a peripheral line like dopamine in the ER. May have to start with a peripheral line before you have a central line. It's not ideal because it can extravasate and lead to necrosis. This is very serious, and there's some special medication that you would have to use as an injectable, but it's very serious. Ideally, you're always going to that central line, and if the patient's going to be in the ER for a while, then you would hope that you would be able to work with your team to have a central line, because really the risk is high. You're going to have to monitor much more intensively. It's best for patient care. So again, that difference, Leslie, you're expecting your patients to have central lines, or that you're going to move on that very quickly. The team's going to get those lines in. In the ER, you may have to start something with a peripheral line until you can get somebody in there to start a central line, or until the patient goes upstairs.
And if I could also just jump in here, that this line needs to be well secured. There's different types of securing devices. So I always say if you work at a rich hospital, you have those stat locks. So it's a little device you stick on the skin, and it will grab it. You feed your tubing through that, and it actually locks it in place. It's a plastic device. It's long term. Like once you put it on, you don't have to change it until it's faulty. But you would that. I'm just used to working in a hospital where we use a tape, and we would tape all of these lines down. Because be careful when you're taping down, you might actually think the tape is holding it. It's not, it has to be around each of those tubings. So just well secured is what I want to make a point.
And you know what I also like looking at that, making sure that you've got your central line here, you've got a triple lumen, and you've got clamps on all of those ends. You're going to make sure that those clamps are open if they're supposed to be open, closed if they're supposed to be closed, and make sure you understand your flush protocol if you're using a flush protocol. Let's see if I can. I'm trying to get this. Whoops, back. Okay. So again, we talked about this just quickly. If you're running out of lines, you may have to run some things together into lines. As Leslie says, you may have to put more attachments together. You're not running both from the same up at the top. You're putting them as low as you can for your attachments typically. You're going to look at what's compatible. You're going to make sure you have that maintenance line. And that's the IV mini bags. You might run antibiotics or some kind of emergency drug that you need. Let's see, flush, you're going to flush before and after those intermittent medications. So critical that you make sure you're not mixing drugs inadvertently. I'm going to show you a compatibility chart on the next page, and absolutely do not hesitate to consult your pharmacist. So here, this is an example of one. There may be some drugs here that are not Canadian. I haven't really looked at it, but this is just an example. Your unit will have its own compatibility charts. Typically, really highlighting the drugs that you're using on your unit. So if you were working on like a medical floor, I don't think you would see this compatibility chart. If you're working in the ER or the ICU, you're going to have this handy and ready to go. Any other thoughts from you, Leslie?
No, just that you want to make sure that the medications are given as close to the Y side as possible, so that they don't have the whole tubing to mix. You want to have it as close to the site as you can, so that they're the least amount of mixing as possible.
And so
and do a visual inspection.
Yeah, let's say I was going to, I have a patient with dopamine running, need to start an insulin drip. I would go across to the dopamine. That's 1, 2, 3, the fourth one down on the left side. And I'm going to go across until I see insulin. Incompatible. So that tells me the I is incompatible, the C is compatible. That tells me those need to go in separate lines, right? Those two are incompatible, separate lines. And this is just, again, a practice concept. Consider more than just whether those can go together, but how are they going to be used? And what you don't want to do is, we talked about this already, interrupt that vasoactive drug, right? So that you end up giving a bolus of dopamine or dobutamine or something like that, because those drugs really should be given in a line, if at all possible, really should be given in a line that is a dedicated line for those vasoactive drugs, because they require such small dosages to have a large impact on their patient. So wherever possible, you're always giving those vasoactive drugs in a dedicated line. If you're titrating because you're adjusting the dose, you want a separate line if you can, if at all possible. Now, when we've got those 8 drips, I don't have separate lines for all those medications. I don't have 8 separate ports. I'm not putting in 2 central lines and 2 peripheral lines and an IV in someone's foot. We're not doing that. But I would look at what is compatible, and also what are they being used for, how often they're being adjusted, what is the likelihood that if I had a bolus or an interruption, that's going to have a profound effect on the patient. So you're really using your own judgment based on those principles about where you're going to be connecting medications. Even if they are compatible, you're still using the best option to be connecting those lines. Okay, this is the same with any medication, a PO medication, a topical medication, some eardrops. Verify the drug and make sure you followed all those administration rights. Remember, it used to be, what was it, like 3 rights, then 5 rights, and now it's, I don't know, 27 rights. But anyways, following all of those administration rights to be giving a medication, right? Okay. Administration. Every single time you're about to give a drug, say, this is the last chance I have to prevent making an error. Am I sure? And for me, I always follow, no matter how fast I'm working, and I am lickety split fast, I follow a clean process, no matter how much you're pushing. I remember one time a doctor was yelling at me, a patient was having a seizure, and I had to give him some weight-based Ativan. And the doctor was yelling at me, draw it up, and yelling at me so much. It's one of the few times in my life I ever froze mentally and could not do the calculation for how much Ativan I needed. And it was just a curtain, one of the beds in a resuscitation room. I actually had to pull myself out of there, just behind the screen. So I couldn't see, I could still hear. I'm like, what the hell? And I just thought I can't listen to that, because I need to make sure I'm giving the right dose. And I need to make sure I'm doing this calculation. So don't take chances. Make sure you know, make sure you're sure. If it's a fast changing situation, do not hesitate to say to your nurse colleague, okay, go over this with me. Make sure I heard that. Ask if you've heard that. Don't give something if you're not sure. Don't ever give something if you're not sure. And it's your last chance to really ask that question. Have I got this right? Okay, we know this. We're going to calculate the dose. We're going to look at the drip rate. We're going to check all our pump settings. We're going to make sure, as Leslie says, that we've got our pump set with the drug as part of a really important drug patient safety agenda, that we actually have the name of the drug, because that's going to give me some parameters on that. So you can't just start bolusing dopamine. When I put dopamine in, the pump is set with parameters for me. I still could put in the wrong rate and cause catastrophic harm, but I can't. It does provide one more safety element. And Leslie's point, verify with a second RN, but not together. It's sort of like when we used to do blood checks all together, and then everybody would be like, yeah, and you're talking. You have to be careful about that, right? You have to be careful that somebody else is paying attention to this, because a second check is no safer than doing something independently unless that person is actually doing that check themselves independently as well. Okay, I'm going to do a separate one, separate chat, I think, on calculations, because this is getting long. So I'm just keeping in mind concentration. So we want the amount, we need to know the amount of the medication that's diluted in a given volume. So dopamine, we've got 400 milligrams in 250 of normal saline. And then we need to look at what the ordered dose is. So the dose of the medication that has to be administered over time. So we need to look at the units. So depending on the medications, remember we talked about that at the beginning, it might be micrograms, it might be milligrams, it might be mils, it might be units. So for various meds, we need to know what those units are and the length of time that they will be administered. So is it per minute, is it per hour? And so an example of what I would see for dopamine is 5 micrograms per kilogram per minute. I'm recording. Okay. So when we're looking at calculations, we want to know what the rate, the flow rate, and the flow rate. Remember we talked about dopamine. So we've got dopamine in micrograms per kilogram per minute, but the flow rate is in mils per hour. Not mils per minute, it's mils per hour, right? So regardless of all those units that I'm using, we're talking, the flow rate is converted, the flow rate is in mils per hour. And in knowing those mils per hour, I also know how many mics that is. Okay. And it's important, we're going to talk a little bit more about this quickly. Patient weight. Some drugs are weight-based. Dopamine is a really good example, and some drugs aren't. So you need to know that. And here we go. So we've got our dopamine, 400 milligrams in 250. The ordered dose is 5 micrograms per kilogram per minute. The patient weight is 70 kilograms. So how many mils per hour will it take to administer that dose? And I'm going to do a separate, we'll do a separate calculation one. Oh, you work on it, and I'm going to answer that in the calculation one. We've got a whole bunch of calculation tools I can use. Oh my God, look at that PDA, Leslie. Isn't that funny? Oh. I hope you're going to use your iPhone. I really hope you're going to use your iPhone. And I really hope that you are going to, again, use the programming in your, on the pump. There we go, IV pumps. Make sure I've got my drug listed on that pump and I've selected it. Make sure it's the units, micrograms per kilogram per minute. Make sure I choose the concentration. So dopamine, do you remember what we said it was? 400 milligrams, right? So we need to know what is the concentration. We're going to enter our patient weight. Isn't this brilliant? Isn't it? It's remarkable, isn't it, Leslie? I feel Stone Age when I was doing all this. We're going to flush our line. We're going to connect it to the pump. So if, for example, if I have a nice clean line and then, and then I want to start running dopamine and I just hang the dopamine bag, but I have a line that has normal saline and I say like, turn it on at 5 mics. It's going to take a long time before that dopamine gets from the bag all the way down to the patient. So I make sure I flush that entire line with drugs so that once I connect it, it's entering the patient immediately, right? So you're going to flush your line when you're starting it with the drug. Any thoughts on that, Leslie?
So that's a really good point. And that also will, that is one of the philosophies of titration, is that you are going to start it. So if you'll be given a range, especially with dopamine, maintain a blood pressure, a systolic pressure of 100 or a MAP of greater than 60. And so I might start it at 5 micrograms per minute, mid-range, to get that down into the patient. So I may start it and then back off. Or conversely, I may start it at a lower dose, 3 mics per kilo, and titrate up. But just be aware that it does, if the flow rate's only 5 or 10 mils an hour, it's going to take a while to hit the patient. But definitely flush that. And that's why we want to have that port right down to the site.
And just keeping in mind, right, so that especially when you're just starting it, as Leslie's making the point, I might start that dopamine at 5, let's say, because I know even if it's a short distance, let's say I'm putting it in a central line, even if you think, okay, it's right in the port, but it's not in the patient yet. Even if you think, oh, that's a short distance to get from that port into the patient, it may take a little while. It may take several minutes to get there. So you have to like hold your breath for a minute and also know, okay, I'm starting at that range, but I'm expecting I may be able to go down in that, or I may have to go up. So you're going to be cautious and judicious, recognizing that if you suddenly start to see a change, it's because the medication has finally hit the patient after, let's say, 5 minutes. Depends how slow it is, but after a couple of minutes, before the patient, the medication gets into the patient's bloodstream, and then it has to have its effect. Most of these drugs are having effects very, very quickly. I think we're getting there. We're going to make sure we've labeled to start the infusion. We make sure the bag is labeled, or if it's pre-labeled. That we're going to make sure that the line is labeled and that our pump is set. We're going to watch for patient response. This is critical. We're watching this all the time. And again, we're going to be titrating to parameters, and that's so critical, right? This is not, somebody's not saying run dopamine at a certain rate. There's always going to be parameters within this. Leslie, now, would you see in the ICU that you have a standard parameter, or are they always going to tell you your parameters, your range?
We have standard range. They're pre-printed orders, so it is a pre-printed range, and it would be within that therapeutic range as well. So we know that dopamine, we're going to run it from 3 to 20 mics. Yeah, I would say very seldom would they limit us, although they might give us an order to, once you hit 10 mics per kilo of dopamine, switch to Levophed to maintain the blood pressure.
Right. The other thing, again, I'm going to say in the ER, often what you're going to have, you're going to be working with a patient who's critical as you're initiating these drips, and you'll have somebody at the bedside with you that says, that is just telling, you know, a physician who's telling you, start some dopamine. We're looking for a blood pressure above 70. Let's get a blood pressure above 70, and then let's see where we're going. Titrate to effect. We've talked about this over and over. You're always titrating to effect. We're titrating to effect with anything. We do that with oxygen. We titrate to effect, right? We're titrating activity. We're titrating activity to effect. This concept is really an important concept. We're always watching the effect of any intervention that we're doing, but in particular, when we're titrating drugs by a more formal process, we are watching the patient and looking at the desired patient response.
And Susan, I just highlight to everyone to document it.
Oh, yes.
So while you may be doing that, so after every intervention, i.e. titrating up your dopamine or titrating up your medication or down, you need to reevaluate it and then document that.
Fantastic. Again, we're looking for the clinical endpoints. What are we looking for? And again, as you go up higher, get to the higher range of a drug, what is the goal of that medication and what are the adverse effects as we give that medication, balancing those, right? So know the action and the indication of a drug, and also know the adverse, the potentially expected adverse effects, and we want to be watching for those.
And Sue, can I just wanted to jump in for 1 second, is that you will get orders to direct it. So when you've got many vasopressors and other effects on your hemodynamic status. So for instance, if you are running dopamine and Levophed and neosynephrine, you'll get guidance from the team, the healthcare provider, the doctor, the intensivist, as to where they want to go. So yeah, increase your dopamine to 10 mics and then max the Levophed out at 5 or 2 mics per minute and add. Or on the other end, as you're titrating off the medication, titrate off your Levo first and then titrate off your dopamine. They won't tell you how to do it or when to do it, but they will give you guidelines as to which one they would like off first. So you'll get that kind of instruction. And it will be, it's really important that, you know, some drugs will have a half-life of seconds and some will have a half-life of minutes. So it's really important to know what they are when you're titrating.
Okay. And again, that idea, when you're titrating, you're going up and down. It's very finessed, right? So don't be thinking, oh my gosh, I'm chasing my tail. Sometimes it feels like that, doesn't it, Leslie? When you're really trying to get to the right rate. It's nice when you've got to a right rate. We're not having to continuously titrate, but any little change can make a very significant impact. So we start a new medication, we're watching a patient. Every time I'm having to make adjustment, unless it's just the very beginning or the patient is critical, I'm always still saying, so what is the underlying cause? Just because I'm able to use dopamine and I'm able to titrate up a little bit to maintain blood pressure, is there some change in the patient that is requiring that titration, or is this just a process? So I'm always keeping an open mind and observing for other things that may be going on, right? And Leslie, a good example is when you talk about that dopamine and you're getting to higher doses and you know you've got that shutdown, so you're going to see mottled legs, those, you know, dusky legs or extremities, because what we care about is blood flow to the core, right? To nourish our vital organs. And so I know that process is happening, but that doesn't mean I'm not checking my patient. I'm not looking at all those things. I'm not noting all those things. So you're paying attention to all of that.
Sue, do you want to comment, and I think this is important, and I don't mean to belabor it, but you talked about how long that the organs could go unperfused before you start to see permanent necrosis.
Yeah, and I think the really big one for me is kidneys. So you've got 20 minutes with a blood pressure less than 60 before you have permanent renal failure. So again, that's a rule of thumb. If you have 21 minutes, sometimes you're fine. But typically you've got 20 minutes. So we all know about CPR and brain oxygenation and other things. But for renal function, 20 minutes with a blood pressure lower than 60 before we're thinking that we're likely looking at permanent renal implications, renal failure. So that's really critical. Because if I'm, as I'm working to bring that blood pressure up, I'm also thinking the clock is ticking. The second somebody is hypotensive, the clock is ticking. And I want to make note of that. And always why it's critical that when we look at our fluid and electrolytes, we're looking at renal function, right? We're looking at our creatinine, our urea. It's so critical. I think, and a good example I give is that years ago, I remember a student telling me this story. She was from Iran. Years ago, there was a terrible earthquake, and then people thought it was miraculous. She was from, I apologize, from Turkey, that they found people 2 or 3 days later, they were pulling people from the rubble, and that was so amazing, and what a miracle that they saved their lives. And it was a miracle that they were finding people after the point where they thought they would not find any survivors. But all of those people who were rescued required permanent dialysis because they had been so dehydrated and their blood pressure had dropped so low that it had renal implications. And so recognizing that our kidneys are our workhorses in our body in terms of our managing that fluid balance, but we have to be attuned to the fact that they require their own perfusion, right? They require oxygenation to be able to continue to function well. I thought this was a great example, Leslie, that idea that we all titrate in the shower. We turn the water, if the water's too cold, we turn it up. If the water's too hot, we turn it down. Titrating is like that. And we don't wait, oh my gosh, I'm scalding myself. Let me wait a few minutes and see if that stays. We turn it down right away. So in titrating, we're responding right in the moment very quickly, right? And you talked about this, Leslie, start in the middle to balance the effect. We don't necessarily start at the low end with the dopamine. You might, if it's ordered 3 to 20, you might start at 5 as opposed to starting at 3. Again, depending on what you're seeing with your patient and where your starting point is, but we may start in the middle. And if you have any questions, start low. And then the rule of 5s. Do you want to talk about that? It's just the, like when you
Well, I think it's just to really simplify the titration so that, but again, you're basing it on the patient, the trends, how they're responding, and that sort of thing. You want to, but always make it easy. You don't want to be calculating 2.5 micrograms per kilo. You want to make it easy what the titration. So you want to go up maybe by 5 mils or 10 mils to the next microgram per kilogram. So make it easy so there's not error made.
Okay. So again, we're continuing to monitor our patient. We've talked about this. We're watching for adverse reactions. We're looking at all of our parameters to make sure that our patient is hemodynamically stable. Cardiac dysrhythmias are very common. These medications have potent effects. So luckily, we all will know how to read a cardiac monitor, and we are absolutely always watching for that. We're watching for excessive sedation or respiratory depression. Now, if somebody's on a ventilator, that's not something we would necessarily be concerned about. But watching for when we're giving sedation, that the patient does not become overly sedated if a patient is not intubated and ventilated. Oh, here's just a chart. You don't need to memorize this. I'm never going to ask you to memorize it. And not all of these are used as commonly, but you see the difference. We've got albumin as an example of something we would give in mils per minute. We've got a whole bunch of drugs that we would give in milligrams per hour. So morphine is a really common one. Lorazepam, Haldol. Did you give a lot of Haldol, Leslie?
Oh my goodness, because of post-pump delirium.
Yeah, delirium is and we need to be very careful that we're also, that a patient, as they have that the last resort may be restraints, but what we want to do is sedate our patient, right? Sedate our patients. so that they're not pulling out lines and creating harm for themselves, but also that we're not traumatizing them further, which is why when we're giving some of these drugs, they have an amnesic effect, and we really draw upon that amnesic effect. Ideally, we would hope the patient doesn't remember their stay in the ICU. We hope we have sedated them effectively enough. So with lorazepam is an excellent example that they have no memory, right? Leslie, what did you say about the shock? What would you give them? So that they wouldn't remember your face?
Oh, yes. So midazolam.
Yeah.
We would give them, although I have since then a bit corrected that it really doesn't have as amnesic effect as we thought. That they still remember that it's us that defibrillated them. But yes, we do need to make sure they're sedated. And some of these drugs, as we can see in this list, are run typically by micrograms per kilogram per minute or micrograms per minute, such as Levophed or nitrous peroxide. Some hospitals do run at micrograms per kilo. So it's not wrong if you see it, it depends on the unit, but these are standard dosages.
Right. So again, just be familiar. You don't need to memorize this. And it's totally fine to have a cheat sheet. Where I believe that cheat sheet belongs is, or that lookup belongs, is on your phone. I think that's your tool, your clinical tool. Again, we're looking at units continued. Not going to worry about that. Where to start. And this is if the doctor doesn't specifically order where you're starting, where you're ending. And Leslie, you said typically your order sets are going to tell you that. But let's say, I don't know, let's say it's not. You're going to start with the lowest dose range recommended for any drug. So we want to start at the low end. Again, we might have for a couple of minutes having it just a little bit higher than that so we get the drug in. We're going to watch our patient response after a few minutes. So these drugs are going to work quickly. We're going to titrate up as needed to get the response we want, and we're going to titrate down as required if there's any adverse reaction. Remember the shower. If it's too hot, we're turning it down. If it's too cold, we're turning it up.
But Sue, I think that's really critical when you say we're turning it down. We're not turning it off.
Right.
We're going to just so slowly, ever so slightly turn it so that we can get a good temperature. So it's very gentle titration and avoiding those big swings.
Yes.
You don't want to have a pressure of 120 and then a pressure of 70.
Right. And also I would just say, I always would say, I'm in this for the long haul. So at the beginning, titrate, like particularly at the beginning, titration it's such a finesse, right? You may go up, you may go down. Other things are happening. A patient is stabilizing after treatment, and it may just, sometimes time is our friend in a way that we don't know. Sometimes time is our enemy. But so it's okay to titrate up, see a reaction, titrate down, everything settles, but now the blood pressure is starting to drop. Do I titrate that drug up, or do I see if there's another drug we want to add to that? So I would, at that point, let's say I had the patient on dopamine. I managed to bring their blood pressure up appropriately, but now I've got some dysrhythmias. Now I'm going to bring that dopamine down, but now their blood pressure is dropping. Do I put that dopamine back up, or do I get an order for another medication, right? So I'm not like just going up and down on one drug. It may be, we use many drug cocktails, right? So using many drugs. Knowing those parameters is important, although again, you will most often find that in your orders. Really important that when we're discontinuing a medication, somebody's really stable, even if they're on a very tiny dose, we're typically titrating them off. We're not just turning it off, boom, turn it off. Catastrophe often will result. So we're titrating them off. Any thoughts from you, Leslie?
Oh my gosh, I had a patient I couldn't get off 0.5 micrograms per kilogram of dopamine. Who's ever heard of that? But that patient required it for their cardiac output.
Yep. And so it's a slow process. Be patient, right? Just be patient. What the book tells you, what somebody else tells you is not as relevant as what you're seeing with your patient, right? So keep your eye on your patient.
Yeah, absolutely.
So we're just looking at a whole bunch of drugs, how you can titrate them, the ranges. I'm not expecting you to memorize this, but this is a good reference, right? It's a great reference. Again, some more drugs. Lots of different dosing regimens or titration of units. We talked about this earlier. Use the dosage measurement, not the flow rate in your calculations, and then set those volume dose limits. And if you're typing in, if you're entering the name of that medication, the pump has some limits for you that will be very helpful. Really, really, really critical that you're programming accurate concentration. And we gave a good example of dopamine, that you can have a single concentration or a double concentration, and you need to know which concentration you're using. And so important, keep an eye on whether it's weight-based. Quick note here. It's hard to know if we're using an ideal weight or actual weight. And what we need to know is whether that drug penetrates fatty tissue. And if we're unsure, we may use this approach that we use the patient's admission weight for initial dose calculations. Now, Leslie, I know you talk about that as well, that after a little while, often when patients are on all of these medications, even though they have a bed scale, we're not changing our calculations, even weight-based calculations, as their weight goes up, because typically patients will become edematous when they're on many of these medications. We're using that, what you called it a dry weight.
Yes.
Weight.
That's correct.
Yeah, so that we're looking at their dry weight. If a patient is very obese, we're going to be asking the pharmacist, what weight are we going to use? We're going to use an ideal weight, or are we going to use their actual weight? It's so important, right? Just ask the pharmacist. And that's a good point. You may ask the physician, but I would, in that case, ask the pharmacist. I might say to the doctor, I'm just going to check with the pharmacist. We have a patient here is 400 pounds and 5'2". So let me just, do you want me to just check, or I'll just check if we're using ideal weight or actual weight? You don't have to keep that in your head, because you've got a member of the team who's going to help you. Any thoughts from you, Leslie?
We only operate from an interprofessional platform, so we do daily rounds or BID rounds. So that would be every member of the team.
Yeah. Okay. And this is, again, we're just going to talk about this. I'm not going to go over it again. We're going to use some drugs selectively penetrate that fatty tissue. So we'll pay attention to that. We'll also pay attention to patients who are underweight, and really knowing, again, what we're using, ideal weight or actual weight. And since we're titrating to patient response, we usually can manage that, but we don't want to start at a very high rate or too low a rate if we're using actual weight, when we should be using ideal, which would be standard weight for somebody who's, let's say, 5'2". Okay, so what are we titrating to? Now, again, you're going to have orders that'll tell you, but in antiarrhythmics, we're titrating to the heart rhythm, right? So we want that, is that antiarrhythmic decreasing the excitability of those heart cells that are leading to that arrhythm, or is it, and that's, I'll just leave it at that. I'm not going to, we'll talk more when we get into cardiac monitoring. Nitrates, we're looking at chest pain and blood pressure. Volume, we're looking for blood pressure, but when we're working in an ICU in particular, we're looking for central venous pressure. We have much more refined hemodynamic monitoring than just blood pressure. And so in the ER, we may be giving boluses to blood pressure. Once we've moved somebody to the ICU, we have many more options for really understanding what's happening with perfusion. Any thoughts from you before I move on, Leslie?
And so in areas where we're not monitoring, we're actually looking at the urinary output. We're looking at cap refill. So we can still do the same assessments. We just don't have the numbers to confirm it. So don't underestimate your ability to assess the patient. Really refine your assessments.
Okay, thank you. And I think so important, and we're documenting all the time because you're going to forget, right? Vasodilators, we're looking at blood pressure and systemic vascular resistance. Vasopressors, same thing. And inotropes, we're looking at cardiac output.
These are numbers that you would, so stroke volume index would be something you would obtain from your PA catheter. And those are they're becoming extinct. We don't see as many central venous catheters, so we might follow their venous gases, and we might do our venous gases and compare them to arterial gases to see what our tissue extraction is. So I think that's beyond the scope of this presentation, but those are some of the parameters we would look at.
And sometimes it's just to be aware. Again, you're not memorizing anything. We're not going to ask you about that. It's just, I want you to be aware of that we're not always titrating to the same thing, right? We're titrating to the effect that we want from that medication. Sedation, we've got a sedation scale. Neuromuscular blockers, we've got that train of 4. Leslie, you're going to say something about that. Analgesics, we are titrating to a pain scale. Heparin, PTT, insulin, blood glucose, you know those ones. Do you want to say something? Let me see. No. Do you want to say something about that train of 4?
Sure. And so with this, when we're titrating neuromuscular blocking agents, we have to follow both the sedation scale and we're assessing the amount of paralysis. So for the train of 4, we have these ECG electrodes is what they essentially are. We put them on the ulnar nerve and we connect it to a nerve stimulator. and it's just two little wires. And so it's actually, this is its function. So I'm going to turn the button to say, do a train of 4, and then I follow the thumb. I want to watch the thumb. And if they have no movement in the thumb, then I would suggest that they have too much neuromuscular blocking agent, and I need to decrease it. And if they are having too much, if they have too much action in their thumb or no action, I have to decrease it. And if they're having too much action, so they have 4 flickers of their thumb, then I have to increase it. So it's really much more of a objective way. We used to just monitor their eyelashes. If they move, we gave them more neuromuscular blocking agent. So it's a nerve stimulator. And also we're assessing the sedation scale. Now, it is very difficult when they have a neuromuscular blocking agent, so we just make sure they have sedation. But in some of the advanced ICUs, they do bispectral monitoring, so they have electrodes on their head, but that's in an advanced ICU.
And just a reminder that the neuromuscular blocking agents are what we're using for paralysis. Titration priority. First of all, is the drip to be titrated? 2, is it titrated to what? Remember, we just talked about that. Are we titrating it to blood glucose? Are we titrating it to blood pressure? What are we titrating it to? And how urgent is this, right? How critical is that titration? So we're looking at responses that happen very quickly, so less than 5-minute response, volume, those vasopressors, think vasodilators, positive inotropes, and insulin. Also some of the antiarrhythmics. You're going to have a response in less than 5 minutes. So you're not leaving the room, you're not changing it. As soon as you're changing it, you've got a plan. You're not thinking, oh, my other patient may be needing something urgently. You're in there, you're watching it every second until you're starting to see a response. Greater than 5 minutes. Oh, no, sorry. Secondary ones, we're going to look at sedation or analgesic. Not that it's not important, but these ones on the left, in the left column, we are thinking typically often life and death, right? Can I bring their blood pressure up? Can I impact the lethal heart rhythm that I'm seeing? So I want that response in less than 5. It's going to happen within less than 5 minutes, and I want to start it immediately. Other things I can do as less significant. I'm still going to initiate them immediately or as quickly as I can, but I'm expecting it will take longer, right? It will take longer. Anticoagulants, they don't work within 5 minutes, right? Antibiotics, I don't see. Don't you wish we saw an antibiotic response within 5 minutes? Wouldn't that be fantastic? But we don't. Antibiotics, we're typically thinking 48 to 72 hours, right? And much longer. When we're looking at electrolytes, just cross out that bicarb. I just don't want to talk about it. I just want to put brackets around bicarb for now. We could have a whole 3-hour talk about bicarb. So complicated. But when you're looking at electrolytes, interesting rule of thumb for me is potassium. You know how we have a higher concentration of potassium within the cell, lower concentration outside of the cell. And so when we're giving medications to have a potassium going inside and outside of the cell to equal. Now, when we give insulin, that can have a very quick impact and drive potassium into the cell very quickly. And we do that for hyperkalemia in response to acute hyperkalemia. We also give some D50 to manage the other effect of insulin, which is to lower blood sugar. But often when we're giving potassium by intravenous, so I've got my IV 2/3 and 1/3 with 20 of potassium, it takes 6 hours. We're expecting 6 hours for potassium movement inside and out of the cell. So that's a good marker that if I've started a potassium, or if I've added some potassium to my IV, if I take electrolytes in 2 hours, I'm not expecting to see that change yet, or I'm not as attentive to it unless it's dropping, as I would be after enough time to really see that effect. What day is it? Today is Friday. TPN takes a while, and then we've got our non-titrated drips. Oh my God. And we're keeping in mind that our secondary drips may become primary if something is happening. Urgency of titration. We've always got to have in our mind, which is the drip of a priority? What drip is the most important for me in this moment? And that will change depending on how the patient is responding, right? Depending on how the patient is presenting. Is their blood pressure dropping? If their blood pressure is dropping. Hi guys, sorry. It's Friday. 1 second. Is the patient's breathing compromised? Is the patient in acute pain? Right? So we're looking moment to moment, we're looking at our patient to understand what I need responding to. If the patient is highly anxious or combative, do you remember Leslie talked about the delirium post-pump, that how critical it may, that Haldol may be absolutely critical because the patient is otherwise pulling out their central line. Is the arrhythmia developing, right? So blood pressure was the problem, and my and one drip, I'm working with my medication, my dopamine, but now an arrhythmia is developing. I may be working with another medication, or I may be adjusting that. Yikes, is the patient climbing out of bed? So I've got all of these things here. Is the patient is climbing out of bed? Which one matters the most?
Just secure your lines well.
Yeah, so if my patient's climbing out of bed, do I care about my TPM? It's not my priority titration, right? So my patient is agitated. Is my neosynephrine, it's important, but is that my priority? Is my, what is that, Leslie? Diprivan?
Morphine and Diprivan, that's propofol.
Oh, propofol. Oh, that's the one. Okay. So
the nurse's best friend.
Thank you, Leslie. And everybody knows, and this is why we need to know our generic names and our common names, right? The propofol, how quickly does propofol work? Seconds, right? Seconds. And what is propofol going to do? That's going to sedate my patient. So my patient is climbing out of bed. We've got all these critical drips. What am I going to do? I'm going to be looking at my propofol, my Diprivan. So moment by moment, things change. We've got some titration guidelines. Some require a bolus or a loading dose. Some are based on preset guidelines. For example, insulin or heparin, you've got those guidelines. And true titration, real titration requires your clinical thinking, your clinical wisdom, and you're adjusting it every 3 to 5 minutes until the desired effect. And you're adjusting by 3 to 5 of those dosage units. So not always by mil, but it might be by micrograms. It could be by units, other things. And you're in that room. You're not leaving. I guess we're getting to the end. Titration is an art, and it's based on science. That when you're titrating up, we really need to know how long it takes for that drug to have an effect. I don't want to titrate up, not give it enough time, and keep titrating up when I just haven't given it enough time. So you're going to know how quickly a medication works. You're going to know the onset of that drug and the peak. And a good example here is something like nitroglycerin. I can get pain relief, chest pain relief very quickly, and I've titrated up, but I also know when I get to so that's the onset of action. But when I get to my peak, my blood pressure may be dropping. So I'm going to see those adverse effects. So I need to be attending to that. And again, titrating down, you're going to be really attentive to the drug's half-life and duration, right? So what is the half-life of that drug? So I'm titrating down, recognizing I don't want to titrate down too quickly because I still have drug in the patient's system from what they have already received. So a true titration down is I'm going to pay attention to that half-life. Some of these medications have a very short half-life, minutes. Some have a longer half-life. So I'm going to pay attention to that. And here's an example, nitroglycerin, 3 to 5 minutes half-life. It's in quick, it's out quick. And that's why we want to use it. And this is, I think, a good example as well. It's like giving Tylenol and then reassessing pain afterwards, except it's happening in the moment. When we're looking at our titrating up, we're looking at the onset of action and the time to peak, right? When we're looking at down, just reinforcing this, we're looking at the half-life and the duration of action. And we already talked about weaning, gradual and careful. Don't get impatient. Most IV drugs that we're using in high acuity are going to have a half-life of about 2 minutes, 1 to 2 minutes to onset, 10 minutes to peak, and a 10-minute duration. That's worth keeping in mind. So you're thinking how quickly, when we think of Tylenol, I'm just going to be incorrect here. I don't know, what's the half-life of Tylenol? What's the peak of Tylenol? Is the peak like 2 hours or something? I don't know. I'm just guessing. One of you can look it up. But we're looking at minutes, right? Many of these drugs have a 2-minute half-life. 1 to 2 minutes and they're in and working. 2 minutes may be their half-life. 10 minutes till you get to that peak, 10-minute duration. And the frequency that you're giving it depends on a whole bunch of things, the drug characteristics, other kinds of things. Let's see. We want to look at how well or efficiently that your liver and kidneys can, under good conditions, eliminate a drug. So I want to know how that happens, which organ is responsible for elimination, and how that typically works. But I also want to look at liver function and kidney function all the time when I am giving these medications. I need to know if there's an antidote. And this is something, oh my gosh, it dates me, Leslie, but in my lifetime, what a remarkable thing it was when we got Digibind. So,
oh yes,
Leslie and I are just having like such fond memories. We did not used to have an antidote to digoxin, right? So we would be using digoxin, and then sometimes patients would end up with side effects from the digoxin and dig toxicity. And we did not have an antidote for that. We used time, right? Time was the antidote. But that's not always great because it would be very ugly on the monitor with all kinds of increased excitability of those cells. You'd have all kinds of aberrant beats. And Digibind was a remarkable step forward for us to be able to have that antidote. So is there an antidote? We know that, for example, naloxone is an antidote for opioid use. All kinds of drugs have antidotes. We need to know what that is. We need to always be careful looking at the volume status of our patient. Are they hypovolemic, hypervolemic? Have they third spaced a lot of fluid? And sometimes that happens. If we're doing weight-based, we need to have that patient weight. Patients there's a scale, a bed scale. We also need to know, again, remember we talked about this, are we using ideal weight or actual weight? If we're using actual weight, are we using their initial weight? We need to know drug interactions. Rule number 1 here, do no harm, right? So we need to know the actions of each drug and all of those factors that we've talked about in order to be able to titrate them safely. A couple of reminders here. In high acuity areas, patients are more complex. Patients are complex everywhere. They are more complex. And one of this is a really key point. The margin of error is very narrow. And that's why, do you remember that slide where we said the very last chance you have to prevent an error is the point of administration? We are always being cautious, but from the very beginning of considering that drug all the way to the end, we're determining if it's appropriate. We're determining what the actions, we're determining if it's what the expected outcome is for our patient. We're mixing it appropriately. We're checking once we've mixed it that we've got it hung appropriately. We've labeled all our lines. We've set our pump appropriately. We've calculated the dose. We've done all of those things. Keeping in mind, can you believe this? And I think this number is probably a little bit old. In Canada, 23,000 deaths annually. Leslie, do you know an updated number?
There's 235,000 healthcare errors, yeah, and a great proportion of those are medication errors.
Yeah, but 23,000 deaths, which is like just really shocking, right? Most common errors are associated with high alert medications, and most of the time it's around communication. Did the doctor really order something? What am I titrating to? A whole bunch of other things. That really critical step, if you're doing a double check, that it's an independent double check. You're not sitting there talking, yeah, exactly as Leslie described. And really focusing on what are your strategies for medication error reduction. Keep in mind, almost everything we're giving is by intravenous route here. So watch that peak is in 10 minutes. Keep that in your mind. That immediate onset of action, we talked about that, 1 to 2 minutes and you've got a response. They have a short half-life, 2 minutes and half of that medication is gone. And they also can be reversed. Typically we can do a quicker reversal. This is, I think, a really excellent point. I like it. Any drug given by intravenous should be considered high alert. As it's given, it has that fast effect. It's in. It's got that immediate effect. It's irretrievable. We can't make the patient throw up. We can't give them activated charcoal. It's in the bloodstream. And they can cause life-threatening side effects if it's not the right dose. And again, that idea of narrow margins of safety. These were the top 5 high alert medications. And I'm just going to mention them quickly. Insulin, opioids or narcotics, injectable KCl. There was a case about 15 years ago. We used to, in ICUs, ERs, in medical supply, be able to have use normal saline, sterile water, or potassium, and they were all in. Do you remember, Leslie, those plastic? I don't know, plastic tube, and you would twist off a plastic top, and then you would use it. They all were the same. Wasn't that nice? And, you know, marketed by the same company. All were the same tube. They all looked the same, except they had different colored writing on it. Sterile water was blue. Normal saline was yellow. Potassium was purple. You know what happened? People started doing things like flushing normal saline locks with potassium. We had so many patient errors. And what we learned, there were two things we learned. One, that marketing tool was not appropriate. They should, and they were all typically, and in my career, they were side by side in your med cart, right? In your, or in the, you know, in your side by side. So easy to pick up the wrong thing, particularly in emergency situations, or if you weren't paying attention. I don't know. Just, you know, med errors are complex in their origins. But they moved to do two things. One, they moved to not have that same look for all of those medications or all of those fluids. They also moved to have potassium restricted. There were too many med errors with potassium. And so it's really quite restricted, except you will still find it in critical care areas.
No, they've even removed them now from critical care.
Oh, have they? Okay, thank you.
Yes.
Just the risk is just too high, right? Just the risk is too high.
I just want to highlight that hyperosmotic normal saline. That's 3% saline.
Yeah.
They used to have those regular, you could, and now they're restricted as well.
They are restricted, although the place you will find hyperosmotic normal saline is in a trauma unit.
Mm-hmm.
Because often now we're using that hyperosmotic normal saline instead of bolusing 10 liters, trying to, with a trauma, we're also trying to use some of that hyperosmotic normal saline, 3% saline, to pull fluid back, to pull back the fluid that a person has. So we're not just diluting them. Okay, don't take shortcuts, use the smart pump, make sure you've got a pump, don't settle for someone telling you that the budget doesn't allow us to have the most modern pumps, any of that. The system is intended to work for patients, and patient safety is the highest priority. Last one, if you're not sure, ask. Don't be having a conversation. Don't talk to anyone else. Don't be looking at your phone. Don't do anything when you're giving medications, right? Medications, that is your absolute focus. Every time you're giving a medication, I used to say to myself, okay, I'm imagining this could be lethal. So what do I have to, how do I have to make sure that it is not lethal? And then you go through all of those steps, and they have a real urgency to them then. Remember, give the drug a little bit of time to act before titrating again. Remember, we're looking at half-life and how that either going up or down, it may take a little bit of time for that drug to work. When you're changing your tubing, don't let the drip free flow, right? So you're changing your tubing and don't let that drip run. Don't assume anything, right? Oh, this is a good example. So another nurse may have mixed up or put a bag of neosynephrine ready to hang, but instead actually what you want is norepinephrine. So you're going to not take anything for granted. We talked about this at the beginning. Label your pumps and your lines. Know the classes of your drugs and know the target organs, right? So where they are having their effect. The things that we're typically looking at in critical care when we're talking about titrating drugs: hypo or hypertension, dysrhythmias, shock, sepsis, heart failure, and respiratory distress or sedation. Here's an agitation scale, one of the agitation scales that we're looking at when we're giving sedation. And this is what you talked about, I think, this bispectral monitoring.
Yes, correct.
We're not, I think that you would not, it's not that common to see this. This is a very... No,
that's at UHN in their ICU.
Yeah. Again, heparin protocol, I'm not going to go through it, but you're going to have that, you're going to have your parameters. And so you're titrating heparin, we know this, PTT. Labeling your lines, we know this. Oh, the gremlins, it's that, you think you've labeled all your lines, you've put all your lines all in perfect place. The next nurse comes in and is like, what the heck? It looks like a mess here. But it's because you're constantly moving, you're constantly working with things. And that's why at the beginning of your shift, you're not thinking, oh my gosh, that's a mess. You're thinking, let's start at the beginning, right? Start at the beginning. But even the best situation, think of that very first picture with all of those lines. You know that they're perfectly labeled and they're all in order and they're ready to go. But to the naked eye, they may not look that way. That's why, again, remember, you become the car, you become that whole room, that patient within the context of all of their treatments and their response to those treatments becomes that view, that holistic view that you have. Summary here. Thank goodness. I bet you're just tired of hearing Leslie and I talk. Know your drugs. Make sure you know how to use that IV pump and you know how to use it effectively, right? So you know how to do it quickly with your eyes closed. When you're starting to use a new pump, not just the in-service, but you've practiced with that new pump before. The first time you have to use it is when a patient is crashing. Drug reference, typically now I'm going to say you're going to have an intranet stuff in your hospital, but also for me, it's phone, right? I know how to look things up. I make sure I've got them, know what resources are most effective. Patient safety matters more than anything, right? Patient safety is our #1 priority. When we're using medications, absolutely working with the physician, but you know, the pharmacist, this is their bread and butter. This is what they do. So they are absolutely, they absolutely have a keen interest in helping you with this. And celebrate with confidence, saved another life, right? It's just the end of the day, you have typically worked your what am I going to say? Worked your feet off? I don't know. I was going to say something less nice. And, you know, often I would say you know, by the time you go home, you're afraid to sit down because your feet will start like feeling that, like you can feel your feet throbbing and pulsating because you haven't been off your feet the entire day. And you're afraid to take your shoes off because if you take them off, you're not going to be able to put them back on. The day of a high acuity day, right? A high acuity day, and honest to goodness, celebrate with confidence. It is so remarkable to walk out at the end of a shift knowing that you have been so intimately involved in helping a patient to make it through another day, or in doing everything you can, knowing you have done everything you can, regardless of outcome, knowing that you have been involved in the very best of care, regardless of outcome. We can't always control the outcome. We can control whether we are involved in providing the very best of care. And that is so critical. Any closing thoughts from you, Leslie?
Well, thank you so much, Sue, for inviting me to join you. This just makes my heart sing. I just love this. And this is truly an art and science. And nurses are the last bastion of patient safety. So that's why it's so critical that all of these points on these 78 slides, while it seems to be a lot, these are all important. And it's just such a sense of accomplishment at the end of the day, when we have, as you said, we've kept this patient alive for another 8 or 12 hours. And that is truly just on nursing. That is because of your skill in titrating these drugs. That is in your skill in assessment and providing those interventions. And not only do we do all these skills technically, but we do it with such empathy and compassion for our patients and their families.
Thank you. And honestly, I just also have to say, this was such a fun talk. Wasn't it just so fun, Leslie? Oh my gosh. I just
enjoyed every minute.
Oh, me too. And I am a little bit envious of you. And I would say, just enjoy it. Really take the moment to really enjoy your growth and your capacity. And the fact that you will be doing something that so few people in the world can do, right? Really, so few people in the world can do. What a privilege, and also what a source of pride. Okay, I think we're at the end. We're not going to talk anymore. I'm sorry it's long. I'm sorry that my dog was barking. My child was bugging. My mom was walking in trying to get coffee. I'm sorry for all of that, but I really enjoyed spending some time with you, and really enjoyed spending some time with Leslie, who brought such an important perspective for us. Okay, we're good, and this is the end, and I sure hope that you have a fantastic day, and we'll see you next time.